Hello, everyone, and thank you for joining us. My name is Amanda Kramer, and I am the Alumni Engagement Program Manager at the University of Colorado Boulder's Lead School of Business. These are certainly trying times, and here at CU Boulder, we have gathered our world-renowned faculty and alumni to provide frank and timely insights for life during and after the COVID-19 pandemic. Today is the final webinar in this COVID-19 related webinar series. Stay tuned for more information about our next webinar series, which starts the week of May 18th. For today's webinar, we're excited to have Professor of Mechanical Engineering, Dr. Shelly Miller, here presenting on how can airborne transmission of COVID-19 indoors be minimized. A few housekeeping items before we begin. First, if you have any questions now or during the presentation that you would like to ask Shelly, please send a question through the chat interface. We will monitor questions as they are submitted, and Shelly will respond to them at the end of the presentation. As a reminder, for optimum audio quality, we do have everyone on mute except for myself and our speaker. If you experience any technical difficulties during the webinar, please notify us through the chat interface, and one of our support specialists will touch base. Lastly, a link to access the webinar recording will be sent to all registrants tomorrow, along with a survey link and supplemental resources from today's presentation. Now, I am so excited to introduce today's speaker. Dr. Shelly Miller is a professor of mechanical engineering and faculty in the environmental engineering program at the University of Colorado Boulder, holding an MS and Ph.D. in civil and environmental engineering from University of California, Berkeley, and a BS in applied mathematics from Harvey Mudd College. Dr. Miller teaches about and investigates urban air quality and works diligently to understand the impact of air pollution on public health and the environment. She is also an expert on indoor environmental quality, including air cleaning technologies. Dr. Miller is a member of the Academy of Fellows of the International Society for Indoor Air and Climate. Dr. Miller has published over 70 peer-reviewed articles on air quality, authored a chapter on indoor air quality in the Environmental Engineering Handbook, is an active scientist on Twitter, and publishes open access as often as possible. Welcome, Shelly, and thank you so much for being here. I'm going to hand the webinar controls over to you now.
Thanks for that gracious invitation to speak here today. I'm really thrilled to be able to do this. And I wanted to share our perspective and my perspective representing all the scientists that are trying to understand airborne transmission and what we can do about it here to you today on this webinar. I'm going to cover three things today. I want to show you some of the information that convinces us that there is an airborne transmission route for COVID-19. I want to hit a little bit on why we also are communicating clearly that crowded, poorly ventilated environments are at most risk for transmission. And then what evidence-based controls we can use to implement our strategies for reducing transmission and keeping people safer as we all open up our communities. I want to start with this graphic so we have a similar understanding of what I mean by airborne transmission. We can define three major routes of droplet exposure. There's the direct spray route, or the droplet-borne route, the long-range airborne route transmitted by small airborne particles, and the fomite route, or touching of contaminated surfaces. Now, this direct spray route can be divided into two subroutes shown here in terms of size of particle and the destination of the particles. The two subroutes are what happens with larger expiratory droplets and then smaller droplet nuclei. And the larger droplets tend to drop out of the air quickly, and they can land on surfaces or on a person standing near you. And then the smaller droplet nuclei can then also be inhaled close to the person that has projected the aerosol onto you. And when we talk about emitted from an infectious person to a susceptible, we're talking about it could happen with talking, with breathing, with coughing, and with sneezing, and then other activities such as singing. This is basically in line with the definitions from the US CDC, Centers for Disease Control and Prevention. However, they don't actually distinguish between these short-range and long-range airborne routes. But this is important because we want to point out that long-range transmission can happen through ventilation ducts or across very large distances. So far, we have not seen a publication in the scientific literature showing that this has happened. So we're still not clear on whether that's an option for COVID-19. But there's lots of evidence to show that transmission is happening close range and the short range and droplet-borne route, as well as a new definition I'm going to add here for you today. It's called the extended short range. And that happens because of crowding and lack of adequate ventilation, which I will cover in the next couple of slides. So this article that I just wrote and published in the conversation talks more about the aerosols and the scientific understanding of where they come from and the sizes and what happens to them. So I'm not going to talk about that today, but this is a great reference for you to read and also to access all of the scientific articles that I've quoted and cited in this particular article. So let's talk a little bit about close contact. Respiratory tract infections are among the top 10 leading causes of death worldwide, and close contact plays a critical role in many respiratory infections. A study done by one of my colleagues looked at, how much close contact are we having in a typical day, and what does that look like? And then this data is used in other studies to understand transmission. But what I like about this is that, wow, most people spend time about a half a meter apart. So we're always in pretty close contact, or we were before this pandemic. The short-range airborne route is found to dominate at most distances studied during both coughing and talking once we understood this close contact problem. So that's this diagram from the previous slide that I wanted to highlight to you. So this short-range airborne route is really how you get exposed when you're close contact with somebody less than 2 meters, which I think is where the 6 feet idea really holds true for this understanding. And then the large droplet route really only dominates in this study that I'm citing here, when the droplets were really large, larger than 100 microns, and when the subjects are within 0.2 meters while talking or half a meter while coughing. So understanding this gives us this information that, well, close contact is why we implemented social distancing, and that's why this is a very traditional approach to arresting pandemics that we've used over hundreds of years. So on to why we think SARS-CoV-2 has some airborne transmission happening. The environmental data suggests this is a route, and papers are coming out every day of environmental sampling showing that, yes, we can detect the viral RNA in the air and on surfaces where air has transported the virus to that location. So the first point is talking about the table on the right. And this paper was just published, and so it is now peer-reviewed and available. But what it shows is that elevated concentration of viral RNA in the air of COVID was detected in a Wuhan hospital and other areas. And it was quite high in certain locations. For example, they found it elevated in the patient room toilet area. And so that is also of importance. So that's up here, patient mobile toilet room. It was quite high in the intensive care unit. Some of the places where they removed apparel was also high, and that indicates possible deposition onto surfaces and then a possible resuspension later. They also found it in a department store and some outdoors, and also, so other locations, especially patient rooms, etc. Yes, I cut off the top of the chart from the paper so that I could put it on this slide, but you can access the paper online. So there were also, I'm going to talk a little bit about the viral RNA. I'll just mention briefly that the first paper that came out we were all concerned when they showed that the surface of the air outlet fan in a room had viral RNA on it. And we thought, oh no, that's not good. That's the first indication that was a few months back that it was airborne. We also want to point out that SARS-CoV-1 was shown to be spread through the air, and we have papers showing that that happened on airplanes, in hospitals, and in apartment buildings as well. I want to talk briefly now about the detections that happened in the Nebraska hospital. This was a really well-contained and well-designed facility to handle bio-containment. And they took a few patients, probably like 13 patients from one of the cruise ships, and harbored them here and helped them recover. And so what they did in this facility was make samples both on surfaces and in air. And the diagram on the left shows the copies of RNA per microliter recovered where they took the sample. And so, you know, they found it in all sorts of locations: floor under bed, miscellaneous personal items, phones, the toilet. And the last three are the air samplers, where they had bedroom air samples and hallway air samples. And the final one is personal air samples, where the sampling was done right near where the person that is tending to the patient had the sampler on them. And so that is a real indication of exactly what you're being exposed to while you're in the environment. And then I just wanted to show you the table on the right from the paper that shows which samples were positive by PCR. And it showed that the air handling rate was 80% positive, and that's similar to the Singapore study I just mentioned to you, and that the all air samples were 63% positive out of 19 samples. And they were able to culture for viability two of the samples, which is important as well, because you can get viral RNA that's not active. And we think between 1% and 0.1% of airborne RNA for viruses is viable. So we also have compelling evidence to show significant transmission in crowded, poorly ventilated spaces. So most hospitals are very well ventilated. They have very strict ventilation standards that they need to follow, but there are also poorly ventilated spaces where we've seen transmission. In Japan, they saw them from close contact in fitness gyms, a restaurant boat on the river, hospitals, and snow festival tented restaurants, for example. We've seen Shelly associated transmission in France, and here in Colorado was where our first outbreaks happened, was in the ski towns. Ski gondola transmission in Idaho as well. An assessment of one of these outbreak investigations showed that you were 20 times more likely to get the disease by being indoors. Singapore clusters from tourist shops, banquet dinners and a church. There was a church associated cluster in South Korea and Washington State. And this 3 family clusters in an air-conditioned restaurant is what I want to talk to you about next, because it's a really important case to understand airborne transmission. First, I want to point out that ordinary speech aerosolizes significant quantities of respiratory particles, and some people are what we call super emitter. So they can emit orders of magnitude more infectious aerosol than another person. And in studies of the numbers of particles that's generated from coughing, there are upwards of 300,000 particles. And then as low as about 6,000 aerosol particles can be emitted in a 10-minute conversation. And again, by way of reminder from my previous point, that the short-range airborne route is dominant during talking and coughing, and then the large droplet is when you're talking, but you have to be really close or really far. So here's the case of the outbreak in the restaurant in China, where we had an index patient here in yellow, A1, that was not showing symptoms of infection yet. They came down with the disease either later that afternoon or early the next day, and they had traveled to this location from Wuhan. And then they ate, because it was New Year's Eve. celebration. So they went to this very popular restaurant and ate at this table with their family members. The outbreak happened with the adjoining tables, these two tables, B and C, and they were not related in any way. They didn't have any close contact with each table, and they can tell that through the video feed of this event. And they don't also associate any of this with the serving staff. They were very minimally in the space. What did happen was that this air conditioner was blowing air and then pulling air back, recycling it through this air conditioner, causing the aerosol to be more widely distributed than otherwise. And the ventilation rate in this space was almost non-existent. There is an estimate in a new draft paper out of the ventilation rate, which is very low. No windows were open and it was cool outside, and there's no external ventilation. Only ventilation in this space would be through open windows, and then they just cool the air by recirculation. So we see the aerosol being transmitted right in this zone, and none of the rest of the restaurants saw the exposure. I know people ask all the time about outdoor air transmission, so I just wanted to mention briefly that this data here was talking about indoor transmission of SARS-CoV-2, and they looked at 7,000 identified cases in China. They only had one outdoor air outbreak involving 2 cases where they had a 27-year-old man with a conversation, and also because they returned from Wuhan. So the graph below shows you the distribution of 318 outbreaks, and what I find very interesting about this information is that most of the cases are transmitted by the family member, or by a family relative. The blue or orange are family member, family relative. And then below is the social connection, social non-connection. And so A and B are different venues, and the highest again is at home or transport, interestingly. On the left, I just show the graphic from the modeling study that hasn't been peer-reviewed yet, but I vouch for this researcher group and this institution doing a good job. This is a CFD simulation showing where the plume of aerosol could potentially go, and so how much distancing you might want to do when you're running or riding your bike. Also want to hit on the point that aerosols of SARS-CoV-2 have been shown in the lab to have a half-life of 1 hour. So they can, if they stay airborne, they can remain infectious for a while. And the half-life means it takes about how long it takes for the amount in the air to decrease by 50%. The highest is on plastic, and then again, the time it takes for no virus. For cardboard is 24 hours, which is why I leave all my packages on my front porch for a day before I bring them in. And then plastic and stainless steel. And plastic is quite a long time, which is why I try to wash all my plastic containers. And air samples show COVID is in the fine aerosol, which is 1 micron or around 1 micron particle size. By the way of context, a human hair is about 100 microns. So you cannot see 1 micron particles with the naked human eye, and they stay aloft for a couple hours depending on the indoor air currents. On to evidence-based airborne infectious disease controls. You're all hearing that you need to wear masks, and I have highlighted the precautionary principle here, which I don't know if I'll discuss briefly, but the point is for masks, you want to wear them if you are asymptomatic or possibly could be infectious, because you don't want to infect other people from this potential. And there are lots of data to show that you wearing a mask can really decrease the amount of aerosol that you transmit. There are the data showing protecting you wearing a mask from another individual coughing on you does not, it helps a little bit, but it's not the real reason why you're wearing a mask. Clearly, we know to wash our hands and surfaces because it is on surfaces. We also are highly recommending that you need to increase your outdoor air ventilation rate and distribute it effectively. Do not recirculate. We also recommend air cleaning and disinfection devices, and I'm only going to recommend 2 here. These are the 2 areas of my expertise, which is germicidal UV and filtration. And then if we minimize the number of people sharing the same indoor space, we will reduce the viral loading and any unsuspected transmission. So just talking briefly about the surgical mask, I'm sharing with you this data that came out recently about respiratory viral shedding with the efficacy of face masks while exhaling your breath. On the left is showing the virus copies per sample of the people in the study, and they looked, and they did have virus in the nasal swab and the throat swab. And when they used the masks, then the droplet particles greater than 5 microns without masks was elevated, and it went to very low detection limit when you wore the mask. And so this is what you are exhaling to other people. And then the aerosol, which is the small fraction that stays airborne, is also released when you don't wear a mask, but it's not released when you do wear a mask. The type of mask here was not really clear, but it's called surgical face masks. So these are not homemade masks, but they're surgical face masks which fit similarly to the homemade masks, in my opinion. This diagram was shared by a colleague, which I appreciated. If you're standing closely and you don't have anything on either faces, your probability of getting sick is quite high. On the other hand, if you have a mask on and you're infectious and you're standing the appropriate distance away, you are really minimizing transmission. And on to ventilation, that we are recommending increasing clean outdoor air supply. We're trying to figure out to what level you need to increase it. Right now, using some modeling, we think it's at least as higher than 10 liters per second per person. Other papers that have done a assessment of health effects from getting sick in buildings and what's the ventilation rate you need to reduce that could be upwards as high as 25 liters per second per person. And it's definitely clear that if you're down below 10 or even 1 liters per second per person, the risk of transmission is quite high. So the data on the right shows how, this was a modeling study, and I think it's from flu, and they were modeling flu transmission. So on the left, the y-axis is the percentage of daily infections. And you can see here that as we increase the ventilation rate to 7 air changes per hour, which is the volumetric flow rate divided by the volume of the space, we get a much reduced daily infections. The lower graph I also like, it's the attack rate, showing that you can go to 0 if you get above 8 air changes per hour. And a little bit about germicidal UV, that's one of my areas of expertise. And what I want to introduce to you about about germicidal UV is first talking about the lamps. So on the left is a diagram showing the output of the lamps. And we commonly use low pressure mercury lamps. And those are the ones on the right that are showing in blue light. And then the germicidal effectiveness has been determined to be around 265. So you inactivate organisms at around 265 nanometers wavelength. So 254 nanometers wavelength comes from a low pressure mercury lamp. These lamps are all, if you're doing it right, you install doped quartz glass, which blocks the transmission of 185 nanometers, which is where we would generate ozone. So that's this small graph here, this little purple diagram. We do not want any ozone in our building. You get it from, ionizers and bringing outside air in that has lots of ozone. But this is the wavelength to generate ozone. The doped glass does not have any of this wavelength in it. This is a UVC LED that's now on the market. We don't use these for large applications like buildings because they just don't output enough power. I want to point out that UVC has some adverse health effects if you're overexposed, and we have exposure limits available from the Occupational Health and Safety Administration, and we know you can get eye and skin irritation. Because the skin penetration is very shallow, it has not been shown to be a human carcinogen like AMB. And here's what happens when you irradiate microorganisms. You cause these a couple of the thymine dimers to conjugate, and then they are not, this RNA is not able to replicate. So this is the application, one of the applications. There are 3 typical applications. I'll just talk about this one for a couple of reasons. It's called upper room air disinfection, where you hang the lamps in the unoccupied upper part of the zone. So, about 7 or 8 feet from the floor. The occupants are in the lower part of the zone, and the lamps are designed so the radiation is going across the room and not into the lower part of the zone. And then the generated virus has to circulate through air currents through the irradiation zone to be inactivated. And for most indoor spaces, there is mixing in the space, and so this does happen naturally. The applications for this kind of technology would be in rooms in which infectious aerosol may be generated, so you do see it in hospitals quite frequently. I've studied 3 applications in Denver hospitals a few years ago, and there may be more now. It's also recommended when you actually really need to increase your air changes, but you can't do it by changing your HVAC because it's just too costly and you can't retrofit your HVAC. So you can add the UV lamps to get additional air changes. And this is where the CDC has recommended UV lamps to be very useful in increasing your air changes. Another place that I always advocate for UV is in crowded environments where unsuspected infectious persons may be present, which is, the case here with COVID, where we don't know who's infectious and who's not. And it has been used quite a lot in jails, especially in other countries like Russia. It's also been applied in homeless shelters and hospital waiting rooms. So this technology has been around for a very long time, and they used it in the earlier part of this century for trying to eradicate and keep the pandemics of measles, mumps, and chickenpox from spreading throughout schools, for example. So this physician installed UV lamps in 3 schools in Philadelphia and studied the outcomes of these disease outbreaks for over 6 years. I like the first sentence of this paper. It reads, "The prevalence of respiratory infection during the season of indoor congregation suggests a natural relationship between ventilation and communicable disease." So one of the outcomes that has been reported from this particular study in 1943 was that the number of susceptibles infected was much lower in the irradiated primary classrooms compared to the unirradiated primary classrooms, despite the fact that there were more susceptibles in the irradiated classroom compared to the unirradiated classroom. And there's other additional studies back in the 40s and 50s. For example, they tried to use UVC in New York schools, and they found that it did modify the spread of measles and chickenpox, meaning it kind of changed the curve, modify the curve, which is what we're all trying to do right now by staying home. So just a brief mention of, for example, data showing why these are so effective. When you install a system according to CDC guidelines, you get upwards of 90% effectiveness applying these lights. And you can get up to 17 additional air changers per hour, which is what our studies showed here at the University of Colorado. I do want to point out the importance of mixing here in the wintertime conditions where we introduced warm air at the ceiling. most US buildings introduce air and exhaust air all in the ceiling. And so if you introduce warm air in the ceiling, it stratifies in the room, and then it causes the inability for bioaerosol to mix into the upper zone. And here are some pictures of the lamp being used in a homeless shelter and in a hospital. So we found, this is another paper which I really appreciated. They used epidemiological modeling to test different strategies for reducing pandemics and outbreaks, and also implemented the effects of engineering controls, including ventilation, filtration, and UV, and found that UV was the most optimal strategy with isolation and vaccination for containing flu, measles, and chickenpox. My last topic is air cleaners. They really work, but you have to know how to purchase the right one. I'm only talking here about portable air cleaners, the kind that you bring into your home if you're worried about exposure to wildfires, for example, which is what most of us have been worried about, but now we're worried about exposure to airborne virus. The clean air delivery rate is how I recommend consumers understand and which product to buy. This is a test protocol that is well done by the Association of Home Appliance Manufacturers. It's supported by scientists and researchers, and they test against dust, tobacco smoke, and pollen. Tobacco smoke is the kind of particle that probably is the same size as the airborne part of COVID, and then dust and pollen would be the larger particle size for COVID. So this clean air delivery rate for this particular air cleaner shows that it can clean up to 100 square foot room. So if you're trying to clean a 400 square foot room, you're going to need 3 of these air cleaners in order for it to work effectively. This is the air purifier if you want to know what I just purchased for my room in the basement where I will be isolated if I ever get this disease. I have this air cleaner ready to start operating. It has a clean air delivery rate of 260, and it's the maximum area for cleaning is about 700 square feet. It's the highest flow rate I could find. It is pricey, but you can get air cleaners that are smaller for about $200. And finally, just showing you what particle sizes are removed in a filter. The y-axis is the fractional efficiency. And all of these numbers are the Association for Heating, Ventilating, and Air Conditioning Engineers testing ratings. And the highest rating, number 16, is a HEPA filter, which is the high efficiency particulate and air filter. And I do recommend considering that at this time, even though when a recirculating mode, you could get a non-HEPA that would work okay. So the HEPA would remove both small and large particles due to particle dynamics that are too complicated here to be discussing. But if you take my aerosol class, then I'll be able to explain why this happens. So you can count on the small particles and the large particles, and then it's a little bit less effective in the middle because of the dynamics of the particle size. So in summary, we have strong evidence for airborne transmission. Apologies for my dog. And this is because we've sampled in the air and exhaust vents. We know SARS was airborne, and there's outbreaks among people who did not come into close contact. The precautions against inhaling the virus are to physical distance yourself and increase your ventilation, add filtration or germicidal UV if you need additional air changers, and to treat the indoor air. And then also I would be precautionary and wear a mask in case you're asymptomatic. Physical distance yourself, wash your hands in frequent buildings that are well ventilated. And this should say spend some time outdoors, just not, super close to people.
Thank you. Please feel free to submit your questions and we will ask Shelly here. Let's start with a question from Paul. What is the most valuable thing that an indoor essential business can do to protect its employees?
I would recommend, first of all, take a look at whether you can increase your outdoor air supply and limit the recirculation happening in your building, and then reduce the number of people in your building at any one time.
Okay, great. And Mark asks, is displacement ventilation an effective means of directing viral particulates to HVAC inlets and therefore exhaust or filtration?
Yes, it's a very good way to make sure that your air is both mixing and moving from the occupied zone up to the ceiling.
Okay, great. And then we have a couple of questions about the study that you referenced in terms of running or walking outdoors and having a runner or biker pass you. What is the compound factor of a breeze blowing toward both of us? What is the recommended distance for runners or bikers?
Yeah, sorry, I don't actually remember that recommended distance. I have a sense it's like 3 times whatever we recommend, so maybe 18, 20 feet, but you'll have to refer back to that paper to really check it out. And I also like moving over, like don't be right directly behind, move over, but check the paper out to get the exact distance.
Okay, great. And then opinion on airflow rates in buildings. Higher velocities may spread droplets further and counteract social distancing efforts. What are your thoughts on this?
Yes, higher air currents do allow the particles to move around the space faster and also deposit on surfaces faster. So that was the concern for the outbreak in China. So I think, making sure that you have adequate outdoor air coming into your space and maintaining a reasonable velocity in your space for comfort. I think that's a good strategy. I can imagine that if that restaurant had outdoor air ventilation at all, the number of infections probably would have been lower.
Okay, great. Thank you. We have a question from Robert. Could you share what technologies are currently being used to detect the viral load?
So most people are now doing genetic tests. So they're doing quantitative PCR, or they're doing some kind of genomic sequencing to rapidly determine what gene is being discovered.
Okay, great. And then a few questions. Milt is asking here about masks. If cloth masks absorb the water droplets carrying the virus from others, can we still inhale the virus through the cloth? Could you tell us more about that?
So there are studies looking at the efficiency of the material, which is different than the fact that you could inhale the aerosol because your mask doesn't fit your face tightly. That's called fit testing, and that is very individualized. Everyone's face is different, and a mask will fit everyone different. So we're always concerned about the aerosol going around the leaky areas and then also through the mask. I would be more concerned with the fact that it goes around the surfaces of the mask, but there are data coming out showing what kind of material is most effective at reducing the transmission directly through the mask. And I would say because you may have potential virus on your mask, you should make sure you leave it sit for a few days before you rewear it or wash it. And I just recently heard this study come out about actually putting a piece of elasticized material around the mask to keep it better fitted to your face.
Okay, great. Thank you for that. Let's see, we have another question here from Michael. What do you think of potential impacts of indoor RH on transmission?
It's a tough question. The reason I'm saying it's hard is because there are some evidence to show that at higher relative humidity, viruses are less active. But there's also some data showing that, viruses suspended, this particular virus or virus like this, suspended in a respiratory fluid is more insensitive to relative humidity. Generally, with a virus, we do think that higher relative humidity will decrease its activity. But right now, from what I understand with COVID, it's being easily transmitted in high relative humidity countries as well as low relative humidity countries. So right now, we can't really say anything more definitive other than that.
Okay, thank you. Next, we have a question from Peter. What about UVGI within HVAC equipment? Is that as effective as the room-based units you described?
That's a really great application for germicidal UV, is to put lamps in the HVAC. And that's typically has been used in the past for a variety of applications. My concern is to make sure you work with a good designer that can tell you the number of lamps you need to put in, because you only have a few seconds for the virus passing through the UV zone to be inactivated. And because of the different high velocities in the HVAC, you can have a high velocity and not enough UV so that it won't do anything. In our studies, we found, in a couple of studies I've seen, around 2 meters per second, you can get effective inactivation, but higher than that, you do not, because you don't have enough UV in the duct.
Okay, great, thank you. We'll take a couple of more questions. This next one's from AG. Are there any recommendations for changing the direction of the vents? And are there any special considerations for tropical climates?
No, I don't have anything to add to that. I mean, I definitely think changing the vents so they don't just blow down on people is probably the best suggestion at this time.
Okay, and then a question from Brian, is needlepoint bipolar ionization technology in the HVAC system an effective solution? There is a product that claims to not generate ozone.
So most air quality experts are more hesitant to recommend ionizing air cleaning for a variety of reasons, including that it does generate ozone, but if it's in the HVAC, it may have deposited onto surfaces and have a minimal concentration by the time it gets to the room. I don't know. A lot of ionizing products also don't have a big enough fan to treat the amount of air effectively. So, there's lots of reasons that filtration works great and air cleaning works great. And then there are other reasons to say, well, we need to look at it a little more closely. So I look at ionizing as a little more closely and don't study that product, so can't say too much about it.
Okay, thank you. And we'll move into our final question from Steve. How long should we let cough droplet nuclei settle before cleaning or disinfecting?
Well, I think if you're worried about people coughing and breathing and putting aerosol around, it could settle within tens of minutes, or it could drop on a surface in an hour or a couple of hours. So I would say, multiple cleanings during the day as you go through your work day, for example, is a really good strategy. I'm hoping that people will be thinking that, oh, I need to clean, for example, at CU in the classrooms, we probably need to clean these classroom surfaces, multiple times a day. Well, how are we going to do that? Because they do get contaminated quickly.
Okay, thank you for that information. Thank you so much to everyone for joining us for today's presentation, and thank you again to Shelly for this great information. As a reminder, all webinar attendees will receive an email tomorrow with a link to the recording of this presentation. To view upcoming webinars as well as previous recordings, please visit our website at colorado.edu/business/alumni. We hope that you will join us during our next webinar series, which starts the week of May 18th. In the meantime, have a great rest of your day and go Buffs!